I'm going to be taking the position that SI joint fusion is a reasonable option for our patients suffering with chronic disabling SIJ pain. And it certainly is nice to be following up all the lectures over the past day and a half, especially from some notable universities, professors from around the world. This is a different scene when I first started making these presentations. One of the things we had to keep in mind as we went down this path of commercialization and development is, you know, writing check after check and believing in yourself and feeling really confident. You really do have to check in with your ego because it can be your enemy. And I've been reading this book, and I think there's a great line here, you know, basically do the right thing. Arthrodesis, well, we've heard from Dr. Wang, you know, that's a very common procedure in orthopedics. That's pretty much what we were doing before arthroplasty. And that's basically immobilizing a joint. And typically this is done for intractable pain, arthritis after trauma, or just wear and tear after age. Well, what other choices do we have? Well, we can do some resection arthroplasties like we do for distal clavicle resection, Mumford procedure. That works very well for people with chronic pain from that joint. And then we have other options like soft tissue arthroplasty, like the CMC joint, the anchovy procedure. I don't think any of those fit very well for the SI joint, so we're pretty down-to-touch arthrodesis. And that's kind of what we do in orthopedics. I mean, we do it for just about every other joint that we don't have a good arthroplasty for. So that's what I did. I decided to just remove the joint, and this is a lateral view. This is done posteriorly. Take off the PSIS. Here, and then remove all the cartilage. I put a little wire in there to show how deep I would go, clean that out, do my typical orthopedic interbody fusion, put some good fixation across. Presto. I was amazed with the results I was getting. Amazing. These people were so much pain, so disabled. And I collected quite a few series of them. The leg pain was almost gone immediately. They had surgical pain, but they said that's nothing compared to the pain I had before. So I went on to give this presentation at many, many meetings as best I could, and the last of which was actually Dr. Harm's meeting in Munich in 1996. But there was so much opposition to this procedure and the idea that this could actually be treated surgically, I had to give up. They were just too brutal. I couldn't take it early in my career. I didn't want to lose everything just for that. So for 10 years, I didn't even talk about it. And then SI bone came back on the scene, or they came on the scene, and they just brought this concept back to life. And so I started my energy to help solve the problem. And here's the reality. It is a problem. We can't deny it. I mean, this slide's been shown many times. And you can see this is just below severe COPD. I mean, that's a major medical problem with a lot of disability. But within this same series of lectures, just about a month ago, they invited Dr. Rashbaum from the Texas Back Institute. And he gave a half-hour presentation on his experience of almost 40 years after starting Texas Back Institute. He decided, you know what, maybe I did miss this. I'm going to look into it more. Now he's done over 100 cases, or at least this institute. And he basically says, you have to be aware of it. If you don't consider it, you won't find it, and then you won't research it. You won't try to figure out how to take care of this problem. So where are we? Well, you know, we know that non-fusion doesn't always work. The conservative measures, so to speak. We saw there was some pretty good results with neuromodulation, but we had the problems with the cost, $20,000 to $30,000 every year or two just to replace the battery. Opioids, obviously a big problem. Maybe regenerative therapy in the future. That would be very exciting. But right now, we do have some MIS-type surgery procedures that are being investigated. The long-term data is pending, no doubt. What do we do in the meantime? Nothing? Hopefully, Dr. Meyer has a better solution. I'm very anxious to hear it. In the meantime, I think united we stand, and hopefully he'll stand with us sometime. Thank you.
So, good morning. To answer your question, no, I don't have a better solution. But the question to me was if I consider SI fusion a must-have, which is a standard of care? And that my answer is no. Well, let me tell you, I'm in the business for 27 years in an academic environment, doing clinical research. I've been principal investigator of 38 randomized controlled trials, of which 24 were industry-sponsored. I'm reviewing for 13 journals, on the average 1.5 papers per day related to the topic. So I'm telling you this, I know every trick in the book, okay? I know how to deal with data. I know how to spin a paper this way, or this way, with exactly the same data. And therefore, the older I get, the more careful I am, what type of information I have, what I do with it. So for the time being, my answer is no, and I will give you the line of arguments why. Outside this room, there's a different world. And there's a reason why the majority of spine surgeons, let alone the majority of doctors, do not consider this type of procedure yet a standard of care. This is taken from the 2 randomized controlled trials. These are the graphs for the treatment effect of the procedure. I've rarely, if not never, seen a treatment effect as large as this one here. This is the difference between the 2 lines. Okay, usually this is very close together. If you're familiar with the sports trials, sciatica trials, you hardly see the difference. As he pointed out correctly, this is a disease which has a huge burden. Okay, this is an important disease, not just something, well, which is rare. So actually, if you publish a positive trial on a disease which is important, you would like to see that quite naturally in the New England Journal of Medicine. So you question yourself, why is that not the case? Why did it not withstand the scrutiny of the reviews of these journals? Well, the reason is, for that discrepancy, that data can be looked, exactly the same data, can be looked one way or the other. I was only here today, but pain related to the SI joint is hard to define. And the tests are ambiguous. So the cohort in which that should actually work is very hard to reproduce. So the first thing to do, which would be my advice, define a cohort. Usually one device is not a magic bullet for all. I know the industry would love to have it as for everybody, because this is, well, obvious. You want to sell this, which is quite clear. Why not? That is your job. But if you widen the indication and don't have a specific cohort where it works, you usually burn the technology. Because society nowadays does not accept this any longer. And you can look at major technologies that have basically vanished, despite the fact that they would be effective in a small subset of population. So narrow that down first, before you convince me. But the major problem is, are the data we have now valid in general? And I believe they are. Don't believe they are, because it's not blinded. You have an extremely large treatment effect, so you have the right comparator. And it's industry sponsored. Coming back to my first slide. So if you want to produce data that are accepted not only in this room by a subset of spine surgeons, but for, let's say, all doctors treating this type of disease, then you need a different approach. You need to compare that with something which is invasive and preferentially a sham procedure. And then you would see completely different treatment effects, I can tell you. It makes it difficult. Because usually, I don't know how it was, I don't know the insights, but I would estimate that it would go that way. The sponsor controls and has all raw data. And he provides usually a selected data analysis by someone who's hired to do so. Then usually a medical writer is also hired by the sponsor, drafts a manuscript. The PI, or let's say whoever, first author, will then review that. The others would just nod to it, then it goes out. That means that the sponsor has the spin on the paper. And it would be completely different if you were independent. So, for the time being, these level 1 evidence studies are not blinded surgical studies with an inappropriate control arm, hardly reproducible population subset. They have an ill-defined disease, have an undeniable sponsor bias, and it's an invasive procedure. We have seen it with revisions and with complications. So I would be very careful to define this as a standard of care for the time being. In your own interest, by the way, because it might happen that otherwise the society will lash back on you and this will be gone before it's on the market in only a couple of years. Be very wise to define clearly a subset of population that is, for which it is beneficial, and then go back on marketing the device on this population. Thank you very much.